Hi guys, it's me again, Gareth Williams, specialist orthodontist. I want to talk to you today about missing upper lateral incisors. 2% of people are missing an upper lateral incisor, but as I've mentioned before, just because something is rare in the populace doesn't mean that I don't see it all the time, because everyone refers these cases to me. Missing upper lateral incisors are more common in Asian populations and more common in females by a factor of 3 to 2. If you have missing lateral incisors, you are more likely to have impacted canines. We know that it is more common on the left than the right. We know it's related to gene penetrance. In line with that, we know that it has a familial tendency. So if you've got either parent who's missing one of these two teeth, or even has smaller teeth in those areas, what we know as diminutive or peg-shaped lateral incisors, then there's a higher likelihood that you are going to have either peg-shaped, diminutive, or missing lateral incisors. We often say that missing or small teeth are rather like looking for mushrooms in a forest. Once you see one, you start to see them all. The most common options we have for you as orthodontists are to accept them and leave them as they are, open the space and restore that resultant space, or close the space and sometimes camouflage the tooth that has been closed into that space as the tooth that is missing. You might have that decision made for you by your orthodontist, or you might find that they present you with both options. Closing the space fully and masking the canine tooth as the lateral incisor, a procedure we call canine lateralisation. If we're closing the space, you can imagine that we need to mask the canine tooth, which is pointy, as a lateral incisor, which is more square. And here's an example of that. In opening the space, you are then subjecting yourself to what we call a restorative burden, in that you will need that space restored for the remainder of your life. And that would either be with a denture, which is a removable plate sort of affair, a stick-on bridge we call a resin retained, or a Maryland bridge. If you don't want a bridge, then your option is having an implant. Now, implants are not indicated in children under 18, and generally implantologists, now the surgeons that place implants, like to wait until around the age of 22 or older. You need to be aware that the long-term maintenance of all other restorations is not inconsequential. Those aren't matters for me as a specialist orthodontist. In any case, that would be between you and the dentist providing you the aftercare following orthodontics. So if you're going down any of these routes, you need to have a chat with your dentist before the braces are placed as to how confident they feel restoring the tooth as another tooth or replacing the space. My only responsibility to you is either to get the space the right size dimensionally for whatever the dentist wants to place, or get the teeth in the right place for the dentist to mask one tooth as another. The ways that we open or close those spaces, a lot of people ask about this, is by way of what we call push-pull mechanics. So where they use little elastics called power chain, which go around the squares and pull teeth away from spaces or pull teeth together to close spaces, or we use push mechanics, which are little nickel titanium or stainless steel springs that wind around the arch wire and push certain teeth apart in certain areas. There are other ways that we move those teeth, of course, but I'd say the basic for most straightforward cases is a combination of push-pull mechanics. If you find these videos helpful and you've got friends with similar issues, if you think that they could help anyone who's undergoing orthodontic treatment, share the videos, please. And if you can, like, comment and subscribe. Thank you for listening. Bye now.